I'll probably get through this in about 20 minutes, half an hour, and there'll be time for questions. I'm going to go fairly quickly through the slides because there's quite a lot of them, and I've got some kind of worked examples at the end, which I'll probably skip unless there are some that are particularly relevant to anaesthetics intensive care. I don't think there are. So this whole process started with Harold Shipman and his murders of several hundred patients about 20 odd years ago now. So the initial Shipman inquiry had two recommendations. One was led to medical revalidation, and the other was supposed to lead to the introduction of a medical examiner system to scrutinize all deaths that weren't investigated by a coroner. For political reasons that I won't go into, the medical examiner implementation was severely delayed, but now seems to be happening, albeit very slowly. In the interval, we had a whole series of healthcare quality related scandals, notably the Francis inquiry into care at Mid Staffordshire, where he was very concerned that after every death, people should be asked what he called the Shipman question. In other words, is there anything that concerns you about the death of your relative? Believing, I think reasonably, that that would have exposed the Shipman murders a lot sooner, and would also have exposed the problems at Mid Staffordshire, where the care was appalling, but the relatives said that they were being ignored. Since then, we've had Jeremy Hunt, when he was health secretary, tried briefly to do something similar by forcing trusts to count what he called avoidable deaths. Well, defining what's an avoidable death turned out to be impossibly subjective. And then very recently, of course, we've had Lucy Letby. So we seem to be back to the situation of a healthcare worker who kills patients. And of course, because of all the delay, there was no medical examiner system at the time when Lucy Letby was doing that. Okay, so what do medical examiners do? After someone has died, if the death is not going to be referred to the coroner for investigation, they gather information from the sources there on the screen. They help the doctors involved to decide whether referral to the coroner is necessary. And we work quite closely with the coroner. So we're a good deal better than that, than the non-medical coroner's officers are. If a certificate needs to be written, we discuss how best to set it out, which is sometimes a bit of a problem, as I'll show you in a moment, and then look for any cases or material that might provide lessons to be learned about healthcare. We also very often find ourselves passing on compliments from the family. We've been doing it in this hospital for longer than most now, and it's gone down very well after an initial degree of hesitancy for the reasons that are on the screen there. Medical examiners have to go through quite a bit of training. There's a national training package that has been put together, which includes really quite a lot of e-learning, followed by at least one face-to-face training session set up, delivered by the Royal College of Pathologists, and then on-the-job training once the medical examiner has started work. So medical examiners do end up knowing a good deal more than most doctors about this field. Here is one of the problems that we have encountered in the past, and I've particularly selected this one for a group of intensive care anaesthetists. I should say straight away that this copy of a certificate of the cause of death is not from UHL. You'll see why that's important. I've blotted out where it came from and who signed it. But the important thing here is the FRCA. This is a death certificate completed by a consultant anaesthetist in a different hospital who worked on the intensive care unit, and one would think was therefore quite familiar with death certification. And in fact, this person has clearly not actually taken any guidance on how to fill in a death certificate in his life, because the standard guidance says do not put down organ failure as a cause of death unless you can say what caused the organ failure. It doesn't. It says that 1A is the final cause of death, okay, lung infection, which is caused by 1B. How does renal failure cause lung infection? Which is caused by 1C. Well, okay, cardiac failure can cause renal failure, but that's a bit vague, isn't it? And you need to realize that these forms are scrutinized by the registry office, whose training is far more legal than it is medical. And if you put something like that down, they're liable to say, well, what caused the cardiac failure? How are we to know it wasn't that someone had shoved a knife through the deceased's heart? That's the way they think. And the other thing on this one is part 2, chronic obstructive airways disease. And if you read the small print, it says that part 2 is for conditions that contributed to the death, which are unrelated to the condition in part 1. Lung infection is probably related to COPD, isn't it? Anyway, so that's just an illustration that although most doctors think that most senior doctors at least, think they know how to complete death certificates, they probably don't. Now, the other question we help with is referral to the coroner. And what's often not understood here is that the coroner's duty to investigate is set out very differently from the doctor's duty to refer. The coroner's duty to investigate is set out in the 2009 Coroners and Justice Act, and you've basically got all of it there on that screen. And it is deliberately vague, like what is a violent or unnatural death? How confident do you have to be for the cause of death to be unknown? If you're in state detention, that's pretty clear, but the other aspects are deliberately allowing the coroner to decide whether it's worth investigating a death or not. But that is the coroner's decision, not the doctor's. So deaths that we should report to the coroner are not the same, and they're set out in a different bit of legislation. This is now from the 2018 regulations that were published most recently. And you may have come across some of these, and some of them are also somewhat vague and difficult to interpret. The commonest problem in hospital practice is death related to any treatment or procedure of a medical or similar nature? What does related to mean? If you're in hospital, of course, you'll have had some medical treatment or procedure of a similar nature. So does that make it related? Well, not unless it actually contributed to the death. Here's some more lists of reasons for referral to the coroner. Neglect is a really tricky one to know what to refer. And was otherwise unnatural is the catch-all at the end. So, there's also a few standard requirements which the law sets out, and these are relatively straightforward and easy to understand. But where there's uncertainty, bearing in mind that the coroner's job is to decide which cases to investigate further or not, the doctors involved in this need to know what the local coroner is likely to be thinking. And medical examiners work closely with the local coroner. So we have a pretty good idea of when referral to the coroner will be a good idea or not. So if in any doubt, consulting a medical examiner on that point is a good idea. So as I was saying before I got the right PowerPoint file, this is has gone down pretty well in hospitals, but then the government finally, nearly 10 years after the Coroners and Justice Act was passed, decided that we really ought to roll it out to primary care, which after all is where Harold Shipman killed his patients. The process was set out to establish medical examiners in all NHS trusts on a kind of semi-voluntary basis, at least not statutory, but NHS England was saying you must do it, and then roll that out to GPs, and eventually, when everything was working properly, make it mandatory. So first of all, GPs weren't too keen, so that got delayed to April 2023. In Leicester, we were all teed up to go ahead with that date, and then it got delayed till April 2024. by which time we'll probably have a general election. So I'm not sure whether this will be when this will become statutory. But if you're working in the University Hospitals of Leicester, using the medical examiner service is a condition imposed on UHL employees. So that's a problem for us and the GPs, not for you. So in Leicester, we, as I said, started making preparations. In June 2021, the NHS sent out what they grandly call a system letter to all GPs saying that you must do this. And I can tell you that most GPs never read it. We have some carrots for GPs, but the GPs were very concerned about the amount of work. And here's why. This is the protocol for medical examiner scrutiny in primary care that was set out along with that system letter. And the problem is not that it's difficult, but that it has lots of separate steps that you can't do all at once. And GPs, being busy people, wanted to sort this out in one session and not wait for someone to ring them back before they could do the next bit. And I think that's probably quite reasonable. And that is still being worked on. Now, we have been doing this for 5 or 6 years. So inevitably, we have been finding a few problems in care. We've also been getting far more compliments about care, which we feed back. Feeding back compliments seems to be reasonably easy, but feeding back information about problems is a lot trickier. And we've learned a lot on how to do that more tactfully than we did when we started, shall I put it like that? Importantly, in UHL, we have bereavement support nurses. And when the concern comes from a member of the family, which is quite frequent, the bereavement support nurses now ring the family and go through the concern in detail and discuss that with the clinical team concerned in, as it says there, a non-judgmental manner, asking questions rather than making accusations. Now, this being Leicester, we have a large Muslim population who wish to bury their dead within, to put it briefly, 24 hours of death before the sun has set twice at least. So there is a need for getting on with it. And one of the concerns was that the medical examiner system would introduce additional steps and introduce delays. There are other urgent reasons for getting a death certificate completed, organ transplantation, and in practice recently, we've had quite a lot of cases where someone comes into the emergency department, a diagnosis is fairly obvious when they arrive, but they die soon after, and the only doctor who's seen them is about to go off shift. So rather than delay that for a few days till that doctor comes back to work, we sometimes do the medical examiner process out of hours to facilitate that. We are available a lot more than the registry office staff, who open briefly on Saturdays and Sundays, mainly for the benefit of the Muslim community. But the Muslim community particularly like this because they are very keen on getting the deceased body to the mosque, i.e. out of the hospital, even if it's not possible to register the death. And UHL policy is now that releasing the body requires the medical examiner to have agreed a natural cause of death. I'm not going to go into what we find in any great detail, partly because I doubt very much that you can see the small print on that screen. But we pick up lots of stuff by the medical examiner looking at cases. And these are a mixture of communications always figures largely, and some errors in documentation, and of course occasionally things that go wrong like they really shouldn't. The sort of medical errors that we pick up are, we've had quite a lot of them, things with management of electrolytes and fluids, forgetting to give some extra steroids to someone who is on long-term steroids and comes in with a serious life-threatening infection, that sort of thing. But it isn't my job to go through the details of that, just to say that we do get quite a lot of stuff. And the biggest single category is arguably end-of-life care. It certainly is if you include themes identified by the bereaved. Most commonly, if the bereaved complain about anything, it's about communications, lack of respect. Quite often it's about staffing levels, but on the whole, they're pretty understanding about that. It's when someone being short-staffed doesn't have time to be polite that the relatives really get upset. Okay, now I've got a few illustrative cases here to show the sort of input that medical examiners provide. Here's just a straightforward death from sphygmoid colon cancer, elderly patient, previous esophageal cancer, managed at home, died. Ever so straightforward, no question of coroner's referral, but the suggested cause of death was that. Now, sigmoid carcinoma doesn't say what sort of carcinoma, and it doesn't say what the sigmoid is. This is what I mean about people not realizing how to fill in causes of death. We all know that sigmoid refers to the sigmoid colon, but you can't expect the relatives or the registry office to know that. Furthermore, esophageal carcinoma has been put in part 2 as a contributory factor. That was treated and cured over 10 years ago. And when you ask, no, it's not a contributory factor. This isn't a list of contributory factors. This is a list of other things that went on with that patient. So we changed that to sigmoid colon adenocarcinoma and stripped out the things that weren't contributory. The wife then gave some nice feedback for the clinical team. Next one, 79-year-old woman with metastatic carcinoid tumor, slowly progressing, expected to die, various comorbidities, fell over and fractured the neck of femur with operative repair. Discharged to the community hospital from where they were sent home for end-of-life care and then died at home. Now, this is a patient with disseminated cancer expected to die, but they've fallen, fractured the neck of femur and had it repaired. That is trauma and medical intervention. Does that justify referral to the coroner? The question our coroner would have us ask is, did those events hasten death? If this bit hadn't happened, would the patient have died sooner or later? In this particular case, we therefore had these two possible causes of death. The one on the left would have required referral to the coroner. The one on the right wouldn't. Now, you've got to tell the truth when you're filling out death certificates. It's a legal document. And it was decided that after the surgical repair, the patient's condition had actually gone down really quite badly. And the people who were looking after the patient felt that if that fracture hadn't happened, she would probably have lived a bit longer. And it doesn't have to be a lot. That means you have to refer to the coroner. But you can refer to the coroner with your choice of information. And if you take the medical examiner's advice, you will refer with this information explaining that the patient was going to die anyway, that the fracture was and surgical repair was a minor contributory factor, that as far as you know, the fall was accidental, although one thing our coroner is very fond of saying is that deciding whether someone fell or were they pushed is her job, not the job of the doctor. So we referred this death to the coroner, and immediately the coroner responded, having spoken to the family and just confirmed the circumstances around the fall. Thank you very much. Please issue as you suggested. And that cause of death is acceptable to the registry office if the coroner has discussed it and accepted it. So that's what happened quite quickly. Okay, so I've just explained what is written on that slide. Another case, fairly rapidly, multiple comorbidities, acute and chronic renal failure, cellulitis, vomiting, hyperkalemia. It was felt that she was not fit for dialysis and was sent home to die and died. Now, the cause of death appeared to be the hyperkalemia. And this is what the doctor suggested. Well, the patient died from hyperkalemia. That's what probably almost certainly caused the final cardiac arrest. The hyperkalemia was due to acute kidney injury. But what caused the acute kidney injury? Dehydration? Heart failure? The trouble is that you can't just put acute kidney injury without explaining the cause, and dehydration or heart failure on its own are not acceptable causes of death for the registrar. Now, in fact, what was probably the main problem here was ischemic, was left ventricular failure. The brain natriuretic peptide was through the roof. And why was the patient in left ventricular failure? Well, partly because of the age, but also because of this was, like most people of that age, ischemic heart disease causing the problem. And of course, she had chronic kidney disease on top of it, which combined with the heart failure to give her acute renal failure. So that is a more internally coherent cause of death, which is acceptable to the registry office. Now, we had an interesting little complaint from the daughter here. Care in the community is exemplary, but she was not happy with care from you lot in hospital. Well, okay. We then got our bereavement nurses onto looking into that further. It was rapidly obvious that from the hospital notes, and here's a prompter for good documentation, that the prospect of sending the patient home had been repeatedly discussed with the daughter, who was frightened, unsure, panicked, didn't know what to do, but really, really, really wanted to get her mother home as fast as possible. So we had collaborated with the daughter to get the mother home as fast as possible, but then the daughter panicked some more, and that's what we were hearing. So this is not really a valid explanation for a justification for a complaint. It's actually more a cry of despair from the recently bereaved daughter. And that's the sort of thing that our bereavement nurses are very good at dissecting out. So you would never have got a complaint about that one because we now handle them a lot better. Finally, this is from a while ago. This is from during the COVID deaths because I was quite proud of this one. 84-year-old Muslim family, known adenocarcinoma of the ovary, wanted to die at home, so was discharged home and then promptly died, not having been seen by any available GP. Now, the Muslim family wanted everything completed within 24 hours because they wanted to get the burial done quickly. Can we do that? This was actually death, as it always is, isn't it, on Friday. So we wound up the online, the out-of-hours medical examiner service. There was no doctor who had seen the patient available that weekend. The consultant responsible for the care could speak on the phone and could confirm the diagnosis. The medical examiner from home logged in and reviewed nerve center, and also we can get to GP records electronically. The medical examiner spoke to the family, confirmed that this was a natural cause of death, and at that point, during the COVID pandemic, but sadly we can't do any more, as a special easement to allow for the pandemic, other doctors had been given authority to complete medical certificates of the cause of death. So the medical examiner was able to produce a medical certificate of the cause of death, scan it and email it to the registry office, who were open at Saturday on Saturday morning, and we got the registration done straight away. And bereaved families are rarely happy, but at least this family was as happy as they could be, that they could see we pulled all the stops out to get things done. Okay, so that's really end of my presentation. I said I'd talk for half an hour plus 10 minutes delay starting. So that's about it. Any comments or questions?
Hi, I'm one of the medical doctors, so not very relevant to the intensive care team. But I wanted to ask, so something like thrombolysis, when we do, there is always a risk of death. And if that happens for a stroke patient, would you refer them to coroners, or is there a no requirement because it could happen as a part of the complication of a treatment.
Right. That's actually a good illustration of how the medical examiner service can get expertise into difficult questions, because what you've just put is, in the individual case, a judgment question. I can explain the discussions we've had, which actually involve the coroner, hematologists, stroke medicine doctors. We've hammered this question, and the answer is basically that if the anticoagulation is believed to have hastened death, then it has to go on the death certificate as a contributory factor to death, possibly in part 2, but it has to be on there somewhere. And if you do that, you cannot issue the death certificate and send it to the registrar, because the registrar will say that's a medical intervention. I'm rejecting that, off to the coroner. So if you think it contributes, then we have to put it on the death certificate, but we do it like the one that I described, in a way that goes, we have to refer to the coroner. We do it as I've described, in a way that allows the coroner to say, thank you very much, I do not wish to investigate this case. That's okay, the registrar can accept it. Whether or not the thrombolysis or antiplatelet drugs contributed to the death is a more difficult judgment question. It's a medical judgment question, and that's where our discussion with the hematologists and stroke physicians came in. The consensus seems to be that if you have someone who is on anticoagulation, as long as it's being given for an appropriate purpose and the anticoagulation is not excessive, it's unlikely to cause a stroke. But if you have a hemorrhagic stroke, it will probably make it worse. From that reason, certainly if you have an ischemic stroke and you're on anticoagulation, then obviously the anticoagulation had nothing to do with it. In fact, it failed to prevent it. But if someone has a hemorrhagic stroke out of the blue on anticoagulation, we're probably not going to refer that to the coroner. However, if they present with a stroke and then it suddenly gets worse, and you find after it's got worse that there's a massive bleed, that becomes this possibility of it being a small hemorrhage or an ischemic stroke, which is then bled because of the anticoagulation. And that means it ought to go on the form. It doesn't mean anyone's done anything wrong, but we refer to the coroner in order to allow us to put the truth on the death certificate without the registrar objecting. When someone is given thrombolysis for a stroke, then my understanding there is it's a situation where you are expecting some of them to bleed and go downhill, but others will do better than they otherwise would have done. And overall, the death rate in response to thrombolysis is not that different, but those that survive do better. That's the justification for doing it rather than saving lives. So if someone is given thrombolysis and then dies, the question is, did it hasten the death? And if you have seen a rapid clinical deterioration after the thrombolysis was given, then it probably ought to be on the death certificate. And to put it on the death certificate, you have to get the coroner's permission to do it. Okay, does that kind of answer your question as best I can, while still leaving you with difficult questions to answer in the individual case?
Yes, thank you so much.
But those are the questions that the medical examiner should help you go through. Hello, I can see an arm.
So, medical examiners at the weekend, what's the easiest way to get hold of if say for organ donation or for an early release? What's the process?
Switchboard. Switchboard, like everyone else on a rota, switchboard have the details of who to call.
Excellent, thank you.
That was quick. Any more questions? Okay.
A last one. What
Yep.
the reason with the COVID or the change in the COVID restrictions, obviously NE's being able to fill in the death certificates. Was there a reason why that got rescinded and it went back to was before?
I personally don't think there was a good reason, but it was introduced as part of a pre-planned pandemic package to facilitate the issuing of death certificates when maybe the doctor who saw the patient was ill or otherwise was having difficulty doing it, so as to not get bodies piling up in mortuaries, really. And it wasn't just medical examiners, it was any doctor was allowed to complete a medical certificate of a cause of death as long as they had taken steps to ascertain to the best of their knowledge and belief the cause of death and that it was natural. So it was actually a pretty massive relaxation of the safeguards in death certification. Now, when it was medical examiners doing it after having talked to a doctor, looked at the notes and talked to the family, it was, to my mind, just as secure in terms of detecting unnatural deaths as the system that we've got. But that wasn't how the law was relaxed. And once we got to the stage of the COVID pandemic restrictions being removed, they just removed the whole package.
Yeah.
So I think it would be actually easier for everybody if medical examiners could discuss the death with the doctor and then issue the certificate themselves. That, after all, is what the coroner does. If the coroner investigates, the coroner issues the death certificate. But we're not allowed to do that.
No, that's it sounds like an excellent idea, but it probably increases the work.
Well, it wouldn't actually increase medical examiners' work that much. It's just be one more form after we've done all the rest of it. It's another example of the law being an ass. But then, what's new?
Thank you.
Okay. If there are no more questions, I have to go and.
Jenny's asked one question on the chat.
Oh, sorry, go on. I haven't got the chat showing. What's
no, it's fine. She said, "What time are you available from and to and at the weekends, or is it a 24-hour thing?"
It's not 24-hour because
Didn't think it would be.
You wouldn't be able to get the body out of the mortuary in the middle of the night.
True.
And certainly the registry office is only open relatively limited hours. But we start at 8:30 in the morning and go until 9 o'clock at night in weekdays, and at weekends and bank holidays it's basically the same. So don't pester us after 9 o'clock at night.
Fair enough. Everybody needs their sleep. Thanks ever so much for doing that.
Okay, well, I hope that was helpful, and good luck, and I'll see you down the medical examiner's office, but not too often, I hope.
Hopefully
Okay.
not.
Bye.
Thank you. Sorry.
Right, so I'm assuming that everyone knows who I am. I'm George, one of the CC3 anaesthetists. Nice to meet you guys. I'm trying to make it interactive. So this is Journal Club. We'll be talking to you about a paper, I believe released last year. It was a I think it was a multi-analysis. Oh Jesus, what's it called?
This is not a good start.
I know it's not a good start. That's it, meta-analysis, Jesus. Right, meta-analysis on randomized controlled trials looking at dexmedetomidine and potentially for the prevention of delirium. So it compared essentially recruited randomized controlled trials to essentially those treated with dexmedetomidine versus those who had either placebo or sort of no intervention. And these was across multiple intensive care units and sort of post-operative care units. So dexmedetomidine, it works on it's an alpha-2 agonist. Hannah, how does that work roughly? Yeah, what happens?
So agonist, so 10 sheets, but alpha-2, so it's like it does what would happen if something bound to the receptor.
So I believe it stops the reuptake of noradrenaline into the pre-synapse.
That was the next sentence.
So essentially calms everything down. Obviously, it's used in maintenance of sedation. That's the infusion dose as recommended by the so BNF, sorry. So it works synergistically. So what you might find is it might reduce your overall propofol infusion rates if it works properly. You need to be careful. If you give it, it can cause second and tertiary heart blocks. It can cause bradycardias. It can also cause uncontrolled hypertension. Patients who've got history of liver hyperthermia need to be cautious with liver impairment. Spinal cord injury, I'm not quite sure why it's an issue with spinal cord injury. Essentially, dexmedetomidine is meant to be 8 times more selective for alpha-2 receptors. So clonidine does have action on alpha-1 in certain dose levels, and also the properties such as a shorter duration of action and a higher potency make dexmedetomidine sort of the preferred drug. It is more expensive. I've not got the true values, but the pharmacist said it's like double digits in terms of the cost compared to clonidine. It's probably why we don't use it first line. These are all the benefits. So from an intensive care point of view, it's got good pain relief. It can provide, obviously, you don't have to do as much propofol, so obviously you don't get propofol-induced myocardial depressive actions of that. It does calm patients down, so we see on patients who might need to know what their sort of sedation weans. Everything there mentioned, I think, is obviously quite benefit for patients on the intensive care unit. Actually, so delirium. What factors on the intensive care might lead to someone being delirious when you're around the room? Adele, name a factor, something which might cause delirium in intensive unit.
Drug intoxication.
Like what? Go on, give me a drug. Type of drug, painkiller, like.
Morphine.
Yeah, cool. Next. Anything.
Any sort of surgery.
Yeah. Tiana.
Environmental noises.
Fine. Anna. Sorry, I'm picking it up.
It's badly soon that I know the answer.
Yeah. No, sure. Anything else? Yeah. Anything else? Fine. Anything else up to this one?
Loads of things.
Fine. So
Electrolyte disturbance.
you can group into sort of host. You can group into host factors, critical illness, and isolated factors. Obviously, patients we see on the unit will often fulfill many of these factors, which I just briefly said. Particularly the ones medications, sleep disturbance after an acute surgical intervention, and quite a lot of our patients do have sometimes hypertension, smoking, things. The ApoE4 polymorphism is a genetic link they found with delirium, which might be some patients might also settle delirium because of their genetic makeup. Yes.
What percentage of patients suffer from delirium on intensive care?
30%. Literally.
What percentage?
Oh,
Yeah.
incorrect.
It's correct, but also incorrect.
It sounds low.
Yeah, between 20 and 80%.
Oh, cheap.
So it can be as high as 80%.
I think the ratios are high because it's just not well diagnosed or looked at, and that's why it's so big.
What I'm sure you're going to talk about the types of delirium.
No. Okay, you have hyperactive.
Yeah.
Hyperactive. There's another one as well. Mix. Oh, is it? There we go. Right. So the meta-analysis, obviously, it had 6 review authors. I think some were from Denmark and some were from China. One of the authors has received a grant from Pfizer. Pfizer do make dexmedetomidine. I don't think they did that. They obviously part of their grants. So this analysis obviously brought RCTs randomized from adults in the dexmedetomidine group and then the placebo mention. It did include RCTs involved with emergency surgery and also elective cardiothoracic surgeries. For some reason, elective cardiothoracic surgeries often get to these sort of big RCTs on the intensive unit. I don't know why. Maybe there's a link between elective cardiothoracic surgeries and delirium. Maybe they're more prone to it. I'm not quite sure. But it is a common theme I've noted in lots of sort of papers I've looked at. So primary outcomes, they wanted to look at basically the occurrence of any serious adverse event, obviously delirium, and then basically all cause mortality. They felt it was important to do this because they felt there was a risk of dexmedetomidine has not been properly evaluated in previous meta-analysis groups. Looking at the list, there's about 60 types of serious adverse events. That can include things like obviously hypertension, bradycardia, heart blocks. It did also involve things like dry mouth and also asystole and other things like sleepiness. So yeah, that was serious adverse effects. It was highlighted anyway. But thankfully, only 2 of the people had that, apparently. In terms of secondary outcomes, I didn't really do much of the secondary outcome analysis, but obviously data that delirium were measured quality of life. They do have specific quality of life IT scores they use in certain units. They also looked at severe delirium and obviously cognitive function as part of the delirium screen. So they pulled all these RCTs from all these data sources. There's obviously almost like a half split between the European side and the Chinese databases, probably because the authors felt more comfortable looking at their own databases. This is just the identification pathway. So obviously they identified almost 27,000 trials, I believe, and obviously they've narrowed it down. So the trials matching the inclusion criteria was only about 270, but they obviously started from 27,000. So yeah. So bias. Anyone want to sort of try and explain what bias is or what it sort of means? Tian, you went here. Bias, roughly. Why would bias be a problem in sort of papers?
I mean, why would it be an issue?
Yeah.
I mean, it'd be an issue because then your data set would, you first look at specific things on data set would either prove or disprove.
Yeah.
Based on what we're looking for. So then it would just cause, that would be the project is just completely useless. I think it's because you're just looking for something.
I mean, you can essentially almost artificially affect the results of your data by potential. So there's different types of bias. I'm not going to go through all of them, but you've got recall bias, you've got the selection bias, you've got obviously potentially.
I mean, you look hard enough for a problem, you'll find a problem.
Excuse me, accuracy.
Yeah. So the authors went through all the RCTs and I basically allocated them to either low risk of bias or high risk. The tool they use is the Cochrane risk of bias 2. It has, I think, 5 or 6 parameters, and obviously, if one of those 6 was deemed to be scoring for bias, then it was put into the high risk. So it was either low or high, 1 or 0, sort of no intermediate risk bias. So obviously, they felt obviously patients, particularly with an acute admission in surgical patients undergoing cardiac surgery, or patients in sort of elderly patients might be at risk of potentially showing like a benefit to dexmedetomidine, which is why they obviously tried to separate the analysis into essentially 2 sets. One looking at only low risk bias RCTs and then all together as a whole. So 95% confidence intervals were used. Anyone want to know what people happy with confidence intervals? Let me see, do you know what it means roughly?
Like where the mean lies between 2 numbers.
So it's you're 95% sure that the true value will remain in that sort of range, essentially. So obviously, the narrower that confidence interval, the more it's accurate, better the data is because it's close to the true value. P-values, so instead of 0.5, they're 0.025 for statistical significance. Okay. As mentioned, obviously, the primary outcomes were separated into low-risk bias trials and then all trials put together. So, looking at serious adverse events, the relative risk for low-risk bias trials had a confidence interval traversing over the value of 1. So, a relative risk of 1 potentially implies there is no definitive opinion that it's better or worse. So yeah, so the true value could be 1 to 1.09, which wouldn't actually prove to be beneficial for using dexmedetomidine. So this is the forest of low risk bias trials. As you can see, you want to look at, obviously, this is the diamonds, this is like the overall pooling effect of all the RCTs named here. And as you can see, it traverses the one value, which means potentially the true value would show no benefit in using dexmedetomidine. And when you look to all trials recruited, oh, that's another one. Yeah, and there we go. So I know it's sideways, just bear with me. These are all this is all trials recruited for the serious adverse events analysis. And the little square at the end, this is sort of a summary, and you can see it is slightly onto the favouring dexmedetomidine group.
Sorry, it's favouring dexmedetomidine against placebo.
Yes.
So there are fewer adverse events in a group that doesn't have any treatment.
So treatment was dexmedetomidine. So it favoured.
Dexmedetomidine in adverse.
So in all trials, it favoured using dexmedetomidine over nothing. To have fewer.
Only in the adverse events.
Yes, but this one was just the low risk bias group.
Yeah.
Which showed essentially no definitive answer. But then in all trials, which is this one.
Okay, sorry, I thought you said that was adverse events. But that's all trials.
Yeah.
Okay.
Yeah, sorry. Yeah. So now we go on to mortality. So again, the confidence interval does surpass the value of 1. However, it's almost beneficial in this statement because obviously it sort of proved, or it sort of suggested that there is no increased risk of mortality in using dexmedetomidine, which is one of the biggest concerns for get onto later in the talk. So obviously, so you're 95% sure that the true value or the true risk, relative risk, lies between 0.18 and 1.21. So this was the forest plot looking at the low risk bias for concerns of mortality. And if you look at sort of the weights of all the trials used, they're fairly even. You've got obviously one with 31%, the rest are 17, 11, 18, 11%, which it's good to have trials with even weights because the weight can influence the overall result of the study if you've got the weight of, let's say, one which has 90% and the other trials having like 2% each. Okay. Moving on to all trials recruited for the mortality question. I'm going to highlight Shahabi, which had a weight of 90%, which has clearly influenced the result a little bit. And I believe the mortality in all trials, again, showed no definitive preference to either group. And with delirium, so looking at low risk trials first again, the confidence interval was between 0.43 and 0.89, and looking at all trials, again, it's a very small graph. Again, it showed preference to the dexmedetomidine site. So the SPICE-3 trial, which was the Shabani 2019 trial mentioned in the previous forest plots with a big significant weight to it, was a RCT which basically found a potentially increased risk of mortality in patients who were sort of just under 65 years. I'm not quite sure. I believe this has come out after SPICE, but in the actual paper it talks about trying to include SPICE and exclude it to see whether there's a significant difference. Clearly, the weight of SPICE is or has affected the analysis looking at all trials. The low risk bias trials did not include SPICE in it. So from the conclusion from the paper, obviously, dexmedetomidine was believed to be beneficial in reducing the occurrence of serious adverse effects. And this paper did try to sort of suggest that there is no increased risk in using dexmedetomidine compared to other placebo or something else. I think I wasn't able to go through the SPICE trial particularly, but that was, I think for the last few years, that's been the big concern of using dexmedetomidine because they did find apparently that so younger patients might not benefit and it might be worse for them in terms of using it and the risk of mortality towards them. So I think this paper was good at trying to separate the trials which only had a low risk of bias versus all the trials together. However, obviously that has reduced the number of trials you can analyse. There's only sort of 5 or 6 in the low risk category. Again, it tried to obviously compare the SPICE trial, which clearly had a significant weight to the results. But I think it overall did suggest that dexmedetomidine is probably safe to use, as there was no increased mortality found across all trials. However, I think obviously, ideally, if you could go and sort of recruit more RCTs in the low risk bias, looking specifically at mortality in that age group, you might get a definitive answer. I believe that's it. It was a very quick assessment of the paper. Any questions particularly? It was a big paper, 60 pages. Yeah, 60 pages, yeah.
Why you took a bit of phone sheet because it's summary.
I didn't look at the guidelines in terms of when we specifically use dexmedetomidine over clonidine, whether there's like a pathway to start with clonidine and an S-based dexmedetomidine. I don't know. Fine.
It's very variable as to when we do. Usually it's actually the younger patients that will start to honestly, there's been a history of delirium and we'll try and get it off. There's a really high chance of having post-operative delirium as part of their treatment. But a lot of the time we'll just go with clonidine. Sometimes I find that the speed of onset offsetting dexmedetomidine is sometimes too fast for the patients. Kind of what you want is for them to slowly surface the risk of a cloud of altitude, which clonidine is very good at. Whereas with the dexmedetomidine, it's just so fast acting. Again, I think in a way we probably haven't used it enough. We kind of use it as and when, rather than using it in a sort of structured started at this point with this person. We don't really have as much experience of using it in theatres. I know some people do use it in theatre, but other places certainly use it. But then they're better funded to get on. But ultimately, it's my personal experience is that unless it's for those people that you just want a little bit of something overnight to keep controlled, then a lot of the sedation side is better managed with clonidine, and then just slowly wake them up. How about, would you agree with that, Zoe?
Is she on? I don't think she's on.
I am
Oh,
busy doing lots of stuff. But yeah, it's a kind of, we don't have any guidelines, do we, as to who we choose and who when we decide to use it. It's just a let's try it because nothing either because something else hasn't worked, or the high risk ones like the substance abusers or difficult people that we think are going to be tricky.
I mean, it would be useful to, or it would be good to know sort of the overall, I guess, intensive opinion on the SPICE-3 trial, because it recruited thousands of patients, I believe, to this trial, which in specific circumstances did suggest that, you know, patients who were 63 odd were at increased risk of mortality. However, when you're trying to analyse papers looking at essentially sick ITU patients with risk of mortality, and if every other co-founder going on at the same time, it'd be interested to look at how they came to that conclusion.
Well, especially if this trial is not led to anybody going, you cannot use dexmedetomidine to
No.
65.
But essentially, when they did take off in the all trial group, which showed no worse outcomes, so no increased risk of mortality, when they took SPICE, I think out of the equation, it's still, or thinking, yeah, when the took spice out, it also reinforced there was no increased risk. But spice does skew the results just from the pure weight it holds. I think a few more specific RCTs may be looking at age and dexmedetomidine compared to nothing might be good, but it was an interesting paper. But I just don't know. I've never, at the back of my mind, thought this could cause a young person to be at risk of death. But then any drug which can cause bradycardia, hypotension, heart block can lead to death quite quickly. So
In an unwell intensive care population.
but yeah,
It's not stopped us.
no.
I suspect people are getting better at using it. As long as you change doses slowly, then you're normally okay.
We don't use the bolus version. do
We don't know.
I think it can be, but I've not come across it. Yeah. Is that consultant approval only dexmedetomidine?
I feel it is.
It's kind of it's not. It's ultimately if you were to start it in the middle of the night, because someone was going batshit crazy. Ultimately, I think if you come in the morning, the patient's not batshit crazy anymore. So they'll go. If we come in the morning and they've arrested and they've got solid, given the dexmedetomidine to someone crazy, then ultimately we might not give you a round of applause or just much slow. But no, I think it's probably a little chat with a consultant. But it's not going to be something. If you find someone's delirious, you're not going to start it within the night. It's going to be should we start on the warfare? Should we start some dexmedetomidine rather than just out of the blue?
But is it fair to say the cost does influence our decision to not have it as first line if other places?
Cost and experience. I don't think I haven't had an incredibly positive experience of it. Because usually the people you want to start it on, the ones that have gone really crazy, you start it on them, and they're still really crazy.
Right.
Like pharmacology, but they still can't control them.
Yeah. And you just need to just go right, back off to sleep, and we'll wake you slowly with something else.
Right.
Yeah, usually.
Does Dave still use it in theatre, Zoe?
Dave, yeah, he's doing emergencies. Why?
No, does he use that? So is it
Not regularly. He has used it for sedation for the difficult kids sometimes, usually autistic ones that have not tolerated other forms of sedation. I don't think he doesn't use it as an infusion in theatre, just for sedation.
okay.
Like pre-op type stuff.
I'm sure it's very good.
Apparently it's worked when he's done it that way, so. But people have started using it for awake fibre optics as well, haven't they?
Oh, really?
Some people have, yeah.